now laughing. Hello. All right. So like I said, this is, let me frame it this way. So, I mean, I didn't get as far as I wanted, but the introductory stuff takes some time. I was trying to get all the way into tetanus, but I stopped a little bit short. So we'll probably end up the same way. I'd like to get through it in two, and even if it takes a little extra time on Friday, have time if you have questions about the exam and things like this. But I was treating wounds and learning about wounds as early as 1975, 76 when I started doing clinical stuff. So I mean, I had an abundance, at least 25 years of a variety of wounds, post-operative wounds, a couple of years of emergency room looking at wounds, a lot of experience with, tremendous amount of experience with diabetic ulcerations. I attended up to 300 nursing home patients during my practice career, a ton of sores. You'll be sick and tired of hearing about bed sores and things like that. So I have what to share. So I'll try to keep it. It's very informative. I bet there's no more than 10 questions on the final about wounds. So it's more of an informational, and you'll obviously know there's going to be a question about burns, and we'll talk about staph, and blah, that kind of stuff. So, I mean, you're going to necrotizing fasciitis, we'll cover today. Tetanus, certainly. Okay, which I was trying to get to. Gangrene, certainly. Those are and lastly, bite wounds, which I have at least one or two questions on. So that's about where the 10 questions come from. Okay. Yeah, don't bite anybody. The human bites are one of the areas that we talk about. So we'll start there. Already you're more interactive than the morning group who were asleep at the switch. Complete. Not everybody. Many. One way, Jose. Let's start here. Okay. Historically, and we'll get there. I was hoping to get to the tetanus, but this is fine. This guy worked with, wrong one. Oh, I got the wrong one. I'm sorry. Whoops to me. I downloaded the wrong one. Oh, it's on your Blackboard. Oh, heavens to Betsy. Yeah, it's down here, 23. I'm sorry. I don't know what I'm doing. I get 25. Oh, I'm sorry. I did it all backwards. You got to go over here to download it. And I courteously waited. So I'm giving you guys a hard time. Sorry, you're good. All right, here we go. So, I mean, this is the part I was talking about. Really, the frame, I framed it like this. Oh, dear. Hold on. Oh, my gosh. Thank you. I have to, I'll get back. That's distracting. I hope this works out for everybody here. It's, when you have somebody you're close with, his daughter had, my best friend in the world for the last 60 years, his daughter had delivered twins that were about 6 to 7 weeks early. But thankfully, I was able to deliver. I had a long phone call last week. Very, very scared that something tragic was going to happen. But according to this, I mean, the news is the fact that they didn't have to take the babies by C-section and they're doing well and she's doing well. I mean, she was 31 weeks and they had to rush her to a big teaching hospital down in Miami. Oh my God. Hey, keep up the good work. That was a pleasant distraction, so forgive me. So she would be a candidate. I mean, we classify things as tetanus and not necessarily the delivery, but could have been with non-tetanus prone wounds and tetanus prone wounds. The vast majority of wounds that you will see or you will sustain or people in your orbit are non-tetanus prone, 95%. The vast majority is cut with a kitchen knife at home. It's relatively superficial. It's in a straight line. It doesn't damage tissue. Clean it up, numb it, put a couple of stitches in, put some steri strips on it, done. The reason not tetanus prone wounds are jagged, they're irregular, they have dead tissue, they have an abundance of debris. We'll talk more about the classifications, but that's something you learn right away. Okay, why, when we ask somebody about having a tetanus shot, why it's so important, it's not, most of the vast majority are non-tetanus prone. We want to know, it's not for coming in, if they're coming into the emergency room or into an urgent care, we got them. We want to make sure that they're tetanus current, because what happens when they're in an accident and people don't get to them soon enough and there's debris? What happens if something tragic happens to them? You know, pick a scenario that could lead to them not getting care as rapidly, or they're being unable to respond to questions. Now you've got to cover. That's the way I view it. I don't know if everybody else views it, but that's, I mean, you're really looking at the what if scenario. It's a whole lot different. And you'll learn the guidelines that are there. So, I mean, one of the things I always do when you know when your tetanus shot is, I was put in the notes thing in your phone. And you know, next time you ask, hey, I had it over at West Penn, whatever, because I got a cut. So this is where he found it everywhere in the soil. And he was able to identify, just like they identify with diphtheria, it's about the toxin. It's not the infection. It's not where the infection is, the toxin getting into your nervous system, or in diphtheria getting into your respiratory system, that causes all the problem. That's a significant feature for a jumping off point. For instance, that's a wound that's obviously infected. Okay, it's red. It's, you can see it. The layers, infection spread side to side. Okay, so what happens when this, whether it was originally a wound that was stitched and opened up, possibly, or whether it was just a wound that was never attended to, or the infection wasn't addressed properly, now that this is gapped open, you can see that yellowish stuff. You can see the surrounding area that's there. And what happens is you start to see this. It's like what you did dissection. You either observed it or did the dissection in the laboratory, how easy it was to be able to like take a finger or take an instrument or the back of a scalpel and separate the layers of tissue. Effectively, that's what we call them, tissue planes. That's how infections spread. We like it if they came out. That's optimal. It doesn't always happen that way. If they don't have a pathway out and we can't incise them, and that's when they spread. That's when they can easily get into the bloodstream. That's when you're looking at potentially tragic complications. So that's what we call this undermining, if you want to use a somewhat fancier term like that. So, and it's different things, and how it works, we look about. And this was part of in that chapter, which was sort of the home study chapter, how nasty they are, how many, how competent your ability is in dealing with infection, and really pertinent to this chapter, what kind of wounds, jagged, irregular, dirty wounds that people who are higher at risk are all potentially tetanus prone wounds. Tetanus is an anaerobic bacteria. When tissue begins to die or necrose, what happens is it loses its blood supply. That means there's no oxygen getting to it. By definition, that is an anaerobic environment. It's one of the reasons, I explained to the other class, we're so cognizant about trying to wash away that tissue, if necessary, debriding, which is removing the debris or debride, both terms you will hear. That people would come into the emergency room, and I was amazed because I was young. I hadn't been in an emergency room, and I did it for 2 years. That was there. I mean, they come in with a cut here, and routinely they'd have, and we did the same thing in the operating room. If we wanted to flush something out that was a big wound or a post-operative area where we've done a lot of work, you want to get all the debris out, we'd have that wound wide open. You have a bucket underneath it or two, and you take these sterile gallons of sterile water or sterile saline, just pour all over just to wash it out. If it was smaller, you take like a giant bulb syringe, like a big sterile turkey baster, for lack of a way of expressing it, and put it into a sterile thing, flush it out, pull it in, flush it out continuously. Because that's the problem. I mean, it's all about the kind of care that you give it that can limit the likelihood or mitigate the severity of, well, that was a very good sentence, and mitigate the severity of the infection. Pardon me, I'm stretching to slap myself on the back for my ability to communicate. Wounds vary. So an incision, by definition, that typical kitchen injury is an incision. In the hospital, they'll call them lacerations. That's more for documentation. It probably has a lot to do with getting paid. Okay, but a laceration classically is there's more tearing. It's more irregular, if you want to get technical. Wherever you're going to be in whatever field you're going to be in, you just, whatever they, basically this is the way we document it. You learn these things. That's just the way it works. Punctures are problems. And my bad artwork comes to display. The problem with punctures, particularly when they're very, like this, the big problem is they tend to heal on the surface, and whatever down there is still down there, and it can kind of fulminate and spread directionally. So punctures are ones that, depending on what you're punctured with, if there's any dirt or debris on it, you have to make the presumption that's tetanus or some other kind of contamination. And a lot of times intentionally we leave those open. For instance, and now this isn't testable, but you might hear the terms first intention for closing. So first intention, secondary, tertiary. And they're different. See, a lot of times your index of suspicion. First intention is in an operating room, we make a cut. You come in with that laceration, takes 5 or 6 stitches, maybe some steri strips. We're going to close it directly, staples. That's called first intention. That's the optimal way to let it heal. If it will heal, a lot of times if you have a large wound that's open like this, and you have some bunch of stuff in there, you go, if I try to sew this, we'll talk about things we don't sew, like animal bites and human bites. The thing is, with the exceptions, of course. The thing with this is if it's real dirty down here, the decision is to do it by secondary intent. Secondary means we're going to let it fill in, we're going to treat it to make sure it doesn't get, with antibiotics because we think it's likely. And if it doesn't, then we'll close it afterwards. I mean, I beg your pardon, that was tertiary, I'm sorry. So tertiary means let it fill and close. Secondary, just let it fill. The thing is, with both of these latter two, I mean, it's something we tell patients, look, there's just too much of a risk of infection, and most likely down the road, 6 months or a year, you're going to have to do something cosmetically, depending on where it is. I mean, and so everybody's different with regard, and I'll share some anecdotes with you about that down the road, about where a scar is. Having a scar, that isn't problematic in some place, maybe folks don't see it or it's not that noticeable. This plastic surgery is just that, by definition, cosmetic. Sometimes it's functional, but that's a different story. So those are all part of it. A contusion is just a bruise. Does that mean the bruise can't cause problems? Of course not. Bruise, you can get fluid, big pocket of fluid called a hematoma that can push on things, that can hurt like anything. Sometimes you have to have it drained. When tissue is damaged, it's going to lose some of its function. That's a part of it, so you have to assess that. Perhaps the most common thing that we see that doesn't need a whole lot is a typical abrasion, scraping a knee, taking a fall, scraping an elbow. I mean, those kinds of things. Me in the garden, me doing the lawn the other day, all sorts of that stuff. That was Saturday's lawn event, Friday afternoon, because before it was going to start to rain. Those are things that happen. Okay, you really don't worry, but just do it with intent. You wash it off, you put some topical antibiotic, good old soap and water, whatever you want to use. We'll do burns, I'll consider separately. I can't stress to you enough. The term burn is we call them thermal injuries. Damage to the skin caused typically by heat or cold, but sometimes by chemicals, radiation, electricity, or just friction. That is basically you're denaturing the proteins right this way. We'll talk about that a little bit more. That's kind of where I stopped before I got to burns in the other group. And we'll see if we get there. If not, it doesn't matter. It's easy to catch up. I talked a little bit about, when you're talking about projectile injury, gunshot wounds, it's a little bit different. I mean, I'm an old movie buff, as you have already heard. I was watching the 1936 version of Last of the Mohicans, Randolph Scott, yesterday. Loved it. Not making any sense to you. It's great. But you know what they used to do in the old movies, the old westerns, or somebody, what did they do if somebody got shot? Oh, we got to dig out the bullet. Why? If the bullet's not near something vital, leave it the heck alone. They sterilize themselves on the way. That's number one. If it's likely to move, it's near a vital structure. Okay, that's something. And it depends on the bullet. I've a couple of gentlemen in here have a little more expertise on these areas that are there. It depends on what kind of bullet, whether it is a hollow tip or a soft tip, or if it's a full metal jacket. If you're unfamiliar, my wife has a carry permit. I don't have a gun. As long as I'm with her, I'm safe. Okay. But I mean, so if you're doing targets, you're using a full metal jacket. If you're trying to hurt somebody, someone's going to explode, basically. And if it explodes, that's a lot of fragments and trauma to dig up, depending on where it is. And bullets do funny things. I told them two anecdotes about this. Sharp trauma, stab wounds and bullets do funny things. We had guys got shot right here. It wasn't the first time. Just right around it, and it must have hit the sternum or a low rib, and it probably was a low caliber because they're, the typical inner city stuff, gang stuff, 25 calibers, 22 caliber weapons. Boom. And it was like I'm on a surgical resident at that point. They call us down from general surgery. We got to take them right upstairs because you got to open them up and look for internal damage. It's not his first gunshot. I'll make the point of it. We couldn't. He had maybe a little nick here or a little nick here that was easy to repair. And one of my mentors was the surgeon, assistant chief, and he's like, "Oh, I don't like this. I just don't feel this is right. There should be more damage." And we weren't even interested in where the bullet was by that there, because you're really doing about the damage. And as we retracted all the internal organs to one side, that you learned about in digestive anatomy, all those things that aren't retroperitoneal, you can move. They're designed to. And we saw what appeared to be a mass that was fluctuating. There was some, as we began to look at it, it almost started to leak blood. It was the inferior vena cava. And he goes, "Luke," he goes, "give somebody else this," because we had somebody else. Let them hold the retractors. You go in there with my gloves, through a surgical gown, push as hard as you can. He goes, "Oh, we got a laceration in the cable. We got to get the vascular surgeon." We're a small hospital, 200-bed hospital, in the middle of a tough section of Philadelphia. Our vascular surgeon was on call. That means 20 minutes to a half an hour he's got to get in. So guess what I have to do for the next 20 to 30 minutes? I said, "What happened, Dr. Garcia? What happens if I move?" "Oh, no, he'll die." "Thank you." "Check, please." And holding it like this. Thankfully, I didn't have to go, because it'd be very embarrassing. If you did not know what happens in surgery, I don't know how they do it for the gals, but for the guys, somebody drops them for you and they get a urinal. That's exactly not that funny. Didn't happen to me. Thankfully, that never happened. We did have some very interesting things with infection, but that's another story. So I'm holding like this. Vascular surgeon got there, fixed it. Next day, we're making rounds. He's up holding an IV pole with fluid and antibiotics, walking around. When did I get out of here? All the surgery he had done. And we saw a couple of those. Guy got stabbed, I don't know, 14 times. It's what they call check day. This will give you an idea. You've grown up with an internet and electronic bank transfers, things like that. Check day was the first of the month, and people would be robbed as they were trying to take their welfare check or their Social Security check to the bank. This guy it was winter. He was stabbed 14 times for somebody to steal a check, an old man. Thankfully, he had a big, thick winter coat. We were amazed at how little damage. I mean, that's why you have to evaluate. This gives you some context for all of those things. So, I mean, not all of you are going to work in an emergency environment, but as I framed it to the other group, Reason I tell you all of these things is if you're going to be a professional, if you're, for instance, for those who are going to go into an RN track, if you're going to be an RN, okay, a license and having passed the test and be licensed to do, people are going to know that they're going to come to you in the neighborhood. Oh, go over, little Johnny, go over, so and so's a nurse. He or she can help you. They do that all the time. So you need to be aware of these things. I'm telling the honest truth. I'm not going to ask you a whole bunch about. These are just, when they say protected tissue, these are tissues that are, how should I say it? We know now that occasionally microorganisms are found there, but it's otherwise we used to call these sterile tissues. And because of that, damage is done. Imagine in the bloodstream, deep in the connective tissues. Typically, when anything gets in there, it's an absolute mess. I was thinking of a more graphic term, but I'll forgo it. And so what you might have started to see if you go back and flip to that initial slide, you see that kind of yellowish stuff that's not the same color. Red and pink is good looking. We call it granulation tissue. Baby blood vessels, cells are coming in. You want to see it. You want to see the granulation tissue. Fill this space up. A lot of times you're afraid it may close over if it's a little narrow. We'll put packing in to intentionally delay it and gradually advance the packing. There's lots of different techniques. When you get to something like this, the mistake people make, I think so, and hopefully I'm trying to say it the right way. In the old days, and maybe our department here is right on top of matters. They used to do what they call wet to dry dressings. It's similar to medieval torture because you're trying to clean up the wound this way. They take sterile 4x4s, wet them with sterile saline or betadine, put them over the wound, and then the next day, peel it off. Well, we're debriding the dead stuff and it's going to make the wound. Nothing, it's medieval. Modern wound therapy, we've learned now that keeping things moist is better. There's a lot of sophistication in wound care. Typically in hospitals and in nursing homes, the wound care officer will be a nurse. My first wife was one of those at a 200-bed nursing home, that she was the weekend and evening supervisor. That's a big job. Because all modern wound care, a lot of sophisticated stuff they can put in here and remove it without having to do those other kinds of things. We would use those dressings differently. When we did a surgical dressing, we'd infuse it with betadine, which was not a good technique, but at least on top of where we closed it. With sutures, we put something called Adaptic, which is a Vaseline gauze, so it doesn't adhere to the wound. I mean, it's different with surgical dressings or not. They're designed to leave on a long time. So all of those things are there, and there's just so much stuff that's involved. So I mean, you could do courses on wound care, and they do them. So I mean, there's a way to debride things. There's a fine mix between keeping it moist and covered and giving it some air exposure time, which I think once you get to a certain point, you want it to dry enough, then you can just use topical care without having to worry about it. Once the defect, so to speak, is closed. I think, and so there's a very much of a fine line with regard to that. This is what I'm talking about. You like it heal from the bottom up. That's where the new cells come in from, the periphery. And this is the mistake when your instructions are culture and sensitivity. Basically, it's a little kid, it's got a sterile swab and a little plastic container. They make the mistake, they culture the pus. Don't do that. Pus is dead white blood cells, connective tissue, fluid, mostly dead bacteria, and a lot of it's surface bacteria. You've got to very carefully try to take a sterile material, a sterile dressing, a 4x4, something, and clean off the wound enough that you can take the sample somewhere along the sides or even into the base. It may hurt, but that's why we pre-medicate people if something's going to hurt. And it's not, I mean, sometimes you have to ask for an order from a resident or a physician or have them call, can we get a pre-med order? Because it's going to hurt to take these cultures. You want to swab them along the base and sides of the wound. That's where the more accurate way, rather than going inside, to be able to find these things. So there's a whole lot that goes along with it. Culture and sensitivity, which you all did in the lab. You identify the culprit, you see what are the likely ways that it can be treated successfully, assuming they are there, and you make an informed decision. And you base that on the culture, you base it on the gram stain. What they do in an emergency room, cultures take 24 to 48 hours. Sensitivity is the same. We do is what they call a stat gram stain. Any test by definition in emergency is stat, meaning it has to be done right away. Blood tests, they get top priority. And you do, and we could do them in the office, do a quick gram stain and take a quick look. And if you see gram positive cocci clusters, it's a staph infection. And we'll go from there. And we call that empiric evidence, and you treat. So here's what pus is, and hopefully it goes out on its own. If it doesn't, now you're going to get that side-to-side spread. And the only way to give it, you have to give it a point of egress, or it's going to travel. And that's where something called incision and drainage comes in. You open that sucker up and get that stuff out. You'll hear about those. That's the other. I didn't even give that. Did I tell you this anecdote about the appendix that ruptured? Oh, I'm gonna love this. This was close to being in my birthday suit, but not quite. I was on my OR rotation, which meant if somebody came up and needed an assistant, they didn't have somebody with them. Do this. Guy came up with a hot belly. They were sure it was appendicitis. Very experienced surgeon. I'm holding the tractors again. He goes, this guy looked. He says, I got a sneaky suspicion that this was a ruptured appendix. Okay, and they're pretty routine. You open them up. It's serious because they have peritonitis. We open them up. We clean it out. We may or may not have to cauterize where the stump was. Yeah, okay, I got it. Me holding the retractors. He's like, whoa. He says, this is where it should have been. I see what happened. He goes, this ruptured and went retroperitoneal. It was covered and it started to be encased in that back wall, which you learned about in digestive and A&P. And so you can feel. Because this is why it didn't have the same presentation. And it's just the two of us. And now this came up. This was assumed to be just a routine appendicitis. They didn't think it had burst. So it was a clean case, meaning that if you have a dirty case, a case with infection, that's the last case of the day because it takes a couple of hours to clean that room with infection. If it's a clean case, it takes 20 minutes to a half an hour to clean the room and get it disinfected so you can. He said, let's incise this and see, get ready because this could pump out a lot of bad stuff. He incised it. Almost exploded out this yuck, the worst smell I have ever by a considerable margin. I was like, oh, everybody, they went, and they had this older lady who was the assistant head of nursing. She about flipped because they called her and she goes, that's supposed to be a clean case. You're killed by room. And she takes it when the room is dirty. Basically, she got towels, soaked them in a disinfectant, put them on the entry. You weren't allowed to go in. We got thankful. We flushed it out, cleaned it out, got it, took the appropriate precautions so it wouldn't become peritonitis. The smell was just unbelievable. You wanted to throw up, but you got a patient right over to it. All said and done, got him fixed up. She's walking around. It looks like an encounter suit. I've never seen. You can see her eyes. So we're still okay. We're gonna go back to the dressing room. She goes, stop. Take that stuff off. Tabs, masks, gowns, okay, all that good stuff. As we start to walk out, she goes, no, we're all in scrubs. Scrubs got to come. That is right. And the only thing I only had underwear, thankfully, down under my scrub, but that's not always the case. And so, let's say we hightailed it it's an absolutely true story. Don't think she's good. Thankfully, I was a little bit more svelte then. It's okay. Don't even start. I'll take this from Indiana Jones and the Last Crusade. Dress, but dress wisely. Think of what you're wearing. You never can tell this will happen to you. I didn't even regale them with that one. Here you are. We're going to talk about this. This is the problem with tetanus. It's also the problem with gangrene. These create an anaerobic environment because there's no circulation and there's tissue damage. So that's where debridement comes from. You have to be very on top of it. And it's not just strict anaerobes. They can be facultative. In other words, they have the, they they can be behave similarly to anaerobes that are there. The big players, once again, Staphylococcus aureus, Strep pyogenes, and one we'll spend some time on, particularly when we get to burns, and I'll amplify it. I'm sure that's going to be tomorrow. The Pseudomonas aeruginosa, which is horrible because it's so difficult to treat. I categorized on my charts, I had a staphylococcal infection. And believe it, the one you're going to see the most of in the hospital, not MRSA, but MERSI. Because you have sick people. And Staphylococcus epidermidis. And MRSA is methicillin-resistant Staphylococcus aureus. A pathogen, even though it grows in our nose. It's on our skin. Methicillin-resistant Staphylococcus epidermidis versus aureus. Normal flora. But in a compromised host, it can be methicillin resistant. It produce the vast number of problems and toxins and enzymes? No. But can it be just as difficult to treat and can it kill somebody? Yes. So every time I had a staph infection and got my sensitivity on my chart, I either had MRSA and MERSI or MSSA for methicillin sensitive. That was the difference. And that's how I document it. I don't know what the appropriate documentation is today, but that's how I would document it. And you treat it accordingly. We didn't have quite as severe problems with finding antibiotics, but this was 25 years ago. It hasn't gotten better. It's gotten worse. We have a few more choices today, at least. So all of these things, delayed healing, abscesses, problems, the toxins themselves, there's so much. We will get to this about Pseudomonas aeruginosa and that characteristic green color. Yet another colorful, literally and figuratively, anecdote coming your way. Next time, I'll save it. So, nostrils and skin, always there. Leading cause, absolutely. Pus producers. I mean, maybe this was an old wound. Maybe this had been sutured. Maybe this is a surgical wound that healed. And all of a sudden, at one part of it, wherever this is, wrist or ankle, some kind of extremity, look what it is. Then all of a sudden, you begin to see it open and stuff starts coming out of it. Now you get a problem. Severe inflammation spreads by blood or lymph. We talked about toxic shock, where you typically don't see it from these. Normally, toxic shock today we see from people unsanitarily and inappropriate without training injecting themselves. Typically, those are for in gyms, locker rooms, performance enhancing drugs, that kind of thing. Human growth hormone, anabolic steroids. Typically, because they want to be so, they want to be very quiet about that. I mean, and this is the problem. And people typically do, I saw you can do this, you can do this. That's really where we see it more than anything else. Problems associated with toxic shock. I mean, whatever you think about it, and I didn't get a reaction out of the other group. If you're unfamiliar, when it's not IV drug users per se. When an IV drug user buys heroin, it's kind of like going to the store and getting a perk. They get you get needles and syringes with it. You get those sterile needles you're looking at the hospital. Somehow they'll come with a 5-pack or a 10-pack. Does that surprise any of you? It should shock people. At least it's preventing deaths from that. But that's what happens. It was extraordinary to show you. I had a tutor before I was teaching full time. I tutored a lot. This young woman, lovely family, had unfortunately a lot of mental health issues, was raped at age 14 at West Penn. They put a 17-year-old or 18-year-old known sex offender in this sort of open area in Western Side. Not West Penn, Western Side. He followed into the bathroom and raped her. And so part of the fallout was then she turned IV drug. And every so often, mom and dad would do a shakedown. So they'd go through her bedroom and stuff. Every so often you just find needles. Back here. 15. Oh boy. Just to give you an idea. So, I mean, these are things, if you're choosing a path in healthcare, these are the things you're going to be, I can't imagine they're going to be any different. I can't. I know there's a different subset of problems based on what I saw 50 years ago. I mean, we had a whole sexually transmitted disease thing. There's probably a whole different world today. Here it is. Staph epidermidis, most common cause of healthcare associated infections. That's an eye opener. CSF areas, more serious wound infections, more common. The staph epidermidis, remember I told you about it? It gets into that glycocalyx, catheters, indwelling orthopedic equipment. I mean, I had to choose when I had to use antibiotics, particularly with orthopedic hardware inside. I was very aware that was something I was working on. You can see all the factors. We talked about them before. It evades your immune system, particularly in the areas it gets into. Your immune system can't touch it in an abscess. Your immune system can't touch it if it's hidden by a biofilm. And again, when we start to see things like this, those super antigens, when you're talking about toxic shock syndrome, that is something that's your immune system with this unbelievable response, with 20% or so of the helper T cells activated and the cytokine storm. I mean, this is your immune system killing you. Okay, this is not as virulent. I mean, tiny suture abscess is easy enough to take out a suture, but the biofilms are a real problem. Tough antibacterial medications to get in, can be carried, particularly bad to tissue elsewhere that's damaged. And if they have heart-related problems like heart valve damage, that's when you're talking about endocarditis. That can be fatal. So much stuff going on. So all these different things. Higher, I mean, if you're a carrier, inherently there's higher risk, even though we all periodically have it. Well, you can imagine all the risk factors. This is the opportunist. And again, we talked about MRSA and all the previous ones there before. I did conjure this up, and I apologize for not being more prepared. When I was doing this last week, thinking about it, this is what they saw an outbreak in another organism less common, this Vibrio vulnificus. Not that I'm going to ask you about it, but all of a sudden there was an outbreak in waters near Florida, and it caused something. I mean, this was in Florida, Bash, and this was the article that came out in 2025 in what they call it's coastal brackish waters are yuck. They're dirty. They got a lot of stuff going into them. The bacteria is bad, and I mean you could get this horrible disease. There's other guys who are in there who you want to stay away from. There are large alligators. I have a non-compete clause with them. I mean, they're there. If you're in that area, the counties that you can see that are there with this, my two little grandchildren, we were from birth to age 4 to 7, grew up right there on the beach, Jack's Beach. and there was a golf course on the naval base, on the naval base that everybody could play. And we had a ton of brackish waters and ponds. They all had alligators. Their home was a quarter of a mile, less than a quarter of a mile away, 300 yards away. You used to say, don't go play on the golf course. Just saying. But look at this. Broward, Fort Lauderdale. Hillsborough is Tampa. Lee County is Fort Myers, Cape Coral. If you're unfamiliar with those things. So that's a less common cause than the one we're dealing with. And the one we're dealing with is Streptococcus pyogenes. There aren't that many cases. But what's meant by necrotizing is this: everything between the skin and the bone dies. It turns, and doesn't just die, it turns into a liquid, pasty, smelly, gassy mess. And the gas is how you diagnose this. It's called subcutaneous emphysema. Emphysema has nothing to do with your lung, even though it's where we see it the most. All it means is trapped air. And all you need when you see somebody, and this is what we did, because we watch medical shows. Oh, get him a CT, we got to do an MRI, we got to do this, got to do that. We used to do plain scout films, regular x-rays. If you would see gas, and you should do this when you see some injury, and it's an index of suspicion. I have seen 2 cases, one in a drug user and one in a diabetic. And it's almost like the skin is expanding, and there's so much pressure from the gas and the yuck that's in there. If you incise it by that time, and all this yuck comes out that's horrible looking and not very pleasant smelling, so it spares the skin and the bone, but gobbles up. Necrotizing means to liquefy. It's a liquefaction necrosis. They had it on the pit, if you were watching, where he incised one. I knew that diagnosis because I'd seen that movie. I knew just what they were driving at. And they try to make it realistic. It's absolutely true. At that point, that person, they would have had, if it was lower extremity, they would not just lost a leg, they would probably done a hip disarticulation. At that point, you're lucky to save the person. That is an immediate surgical emergency. They go to OR now, move everybody out. This is what I mean. It's just like the skin's going to explode. Fulminant means it goes from nothing to a 5-alarm fire like that. And so, I mean, there's different forms that are less. The pain at the side of the wound. And again, the one wound I saw was in a drug addict. The other was in my first wife's wonderful uncle, great guy, right up in Squirrel Hill. And I mean, just such lovely people. And I mean, in his diet, all of a sudden I'm seeing it. And he had the subacute type. I started my antibiotics. It didn't get better. I referred him. I was not practicing here at the time. I was visiting. I referred him to the head of Montefiore's surgery department. And he called me up and goes, the only reason I would know what that was, and all he got was an amputation out of it. Because he had seen one when he was up in Boston in med school as a resident in the 1940s. He's thanking me like, you saved him. I thought I missed it completely. I was kicking myself. So here it is. This is the most common agent. Not that common statistically. All of these enzymes break it down. Typically less than 200 cases from this annually. They just get a lot of ink like that. The other place, and I don't know if it was the same bacteria, that Vibrio, was after Catherine, then the storm went to Houston. There was a ton of flooding. They had a cluster of about 4 or 5 cases there. And that was after Katrina, that hurricane. I mean, most of you guys were little at that point. That was a big mess. That was Category 5 hit right in downtown New Orleans. Oh my goodness. And so, again, super antigen is really what happens. Gobbling up proteins, life-threatening. No other way to say it. Very few. So the ones I saw, diabetes, injected drug use. But there's other things. Spreads so rapidly, immediate surgery, often essential for survival or even anything along those lines. And interesting, this is where I stopped before. So Pseudomonas is what we're going to get to, because the frame for Pseudomonas is so important to understand. Is less so wounds and a whole lot more about burns. So I'll leave it there for all of you. Felt like I raced through that. I hope you find it interesting and informative, because I really think down the road it'll serve you. Thank you.